Good Wednesday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, coming to you live from the Dolph Simons Jr. Family Broadcast Studio. Today, we're focused on the surge in COVID-19 cases and mitigation efforts necessary to care for patients. We'll hear from our medical director at HaysMed, Dr. Heather Harris, who should join us on the phone, and also the Director of Infection Prevention on our HaysMed campus, Kevin Myers. But first, good morning to our Medical Director of Infection Prevention and Control, Dr. Dana Hawkinson.
Hi, how's it going?
Good to see you. All right, good to see you. How do we do overnight?
We didn't do too good. We're about the same where we were yesterday. We have 100 acute infections in the hospital right now, but almost 50% of those are in the ICU, and I know that our ICUs are really strained for beds right now. 48 of those 100 acute infections are in the ICU, with 29 of those on the ventilator, so a high proportion on the ventilator as well. We have 59 in that acute recovery period, so just about 160 total patients. We did have 5 deaths from November 30th to December 1st, however, so we have had some recent deaths as well. And then Hays is doing a little bit better. They have 32 total patients with 23 active and 9 in that recovery stage as well. So those numbers look a little bit better, a little bit lower than they were, but we are still have pretty high numbers, especially in our ICUs.
It's interesting, you talked about the proportion of our ICU patients this morning on the ventilator. That's 60%, give or take.
Yeah.
And that has fluctuated over time.
Yeah.
And I think it's also proof, we talked yesterday a little bit, that we've seen very severe disease in young patients, including people needing to be on ECMO in the past week. So it always amazes me how a snapshot in time doesn't really tell the whole story, but when we look over the course of time, there's a lot of severe disease. So we'll talk more about that, I'm sure, as we get into questions. Before we do, early in the surge, you asked us about steps we were taking here at the University of Kansas Health System to mitigate capacity issues, knowing that patients need care for both COVID-19 and for other diseases. We've talked about how we identify surgeries that can be deferred or delayed a few weeks without negative impact to patients' outcomes to free up beds. In an effort to get some of those beds back available for surgery and to make room for more COVID-19 patients, we started this week moving some of our patients from the hospital here in Kansas City, on the Kansas City, Kansas campus, the main campus, to our Indian Creek campus at 435 and Null. We're only transferring patients who are carefully selected and evaluated and are able to be moved safely by ambulance to another campus. The patients on our Indian Creek campus are cared for by nurses on the 3rd floor of our medical surgical unit at the Indian Creek campus. This shift of patients to Indian Creek helps us increase bed capacity to care for more complex patients or patients with more complex care needs here on the main campus. It's a good example of the ways that we are trying really, really hard and sometimes creatively to manage capacity to make sure that everyone who needs care in our community can get it. Before we jump more into the discussion about COVID-19, the surge, and what all of our mitigation strategies are there any reporter questions this morning?
Sure. Good morning. Cody Holyoke from Channel 9.
Good morning.
We saw that the CDC is planning to lower the number on quarantine and stay at home. I know you guys have hinted at that earlier this week. I think I know the answer to this, but I'd love to hear you explain it. Has the science changed, or is this move sort of being made to placate people, make staying home more palatable to people who are otherwise resistant?
Well, I guess I would start, and I'm going to let Dana weigh in on this pretty quickly too. I would start by saying we haven't really seen any new data or evidence that the CDC may have used in this decision, so it's a little hard to provide full comment. I think that there are a lot of factors in play, though. Your question about is this a move to help make this more palatable for people? I think that's always been a question, and the risk-benefit of how many infections might develop in day 12, 13, or 14 after an exposure as compared to maybe day 7 or day 10 is an important factor to balance. And my guess is, without having access to all the data and evidence, that those sorts of things were involved in the conversation.
Yeah, absolutely. You know, I read the article yesterday. I looked for it on the CDC last night. They hadn't posted it yet that I could see, but they did talk about new data. And we've always said that, you know, our recommendations and our guidance changes as the data changes. So they have talked about having the data. We haven't seen it yet, but obviously this decision will be made on evaluating all the available data. So it may be posted now. I haven't had a chance to look this morning, but we essentially know what they are, just like you talked. It's that 7 or 10 day quarantine with that testing being done as well.
And I think, you know, the final piece I would say in relation to all of that is we've talked before about how rapidly we're learning as a healthcare community and really in the public health space as well about this novel, new disease that we've not had to deal with before. And so many times this is really informed by new information and things that we have learned in that sort of risk versus benefit balance, which does not necessarily mean that the science has changed or that that the original recommendations were wrong or incorrect. It simply was based on the best available information we had at the moment. We've learned since then. So we'll see. I do think that if it is not posted this morning, that we're likely to see more information about how the decision was made and what supporting evidence there is very quickly here. And then I think local, whether they be state or county health departments, will work through how to incorporate that information into their guidance.
Hi, Heather Hollingsworth with the Associated Press. I have a question regarding the use of air transports. I'm hearing from a lot of rural hospitals about patients being flown hundreds of miles there, and I just wanted to see if you have any sense of whether that's up significantly when that happened and how that's playing out at your facilities.
Sure. So we do have an active transfer program, no doubt. We've been along the tertiary or quaternary referral center, meaning the place that offers really high complexity services for a lot of our region, not just our state, but our region for a long time. And so we regularly have patients flown from distances to our hospital that might be too great to travel via ambulance or ground. I think it is very true that more hospitals, more small hospitals, or more hospitals farther from referral centers are having to transfer more patients now, and that is taxing the transport system in general, whether it be ground or air. And there are a lot of complexities there. When we talk about air transport, there's rotary wing or a helicopter, which I think most of us are familiar with, but there's also fixed wing, so specially designed planes that transport patients longer distances. And each of those methods have their own logistical complexities that have to be managed. So it takes an ambulance to get a patient from a hospital to an airstrip, to get on a fixed wing plane, and then an ambulance from the airstrip here in Kansas City to our hospital. So lots of complexities in that, lots of parts of that system that are under stressed or that maybe are taxed in different ways. But in general, I think, yes, there are more patients, it is true, that are being airlifted, if you will, or transported via either rotary or fixed wing, farther distances to get care.
Sicker when they get to you, these patients that are having to be flown?
Well, I think it's true that a lot of these patients are very, very sick and have lots of needs. They wouldn't really be coming if they weren't in that circumstance. I don't know if they're sicker when they get here. Long transport times definitely have an impact. But we also do not load a patient into any transport, ground, rotary wing, or fixed wing, if they are too unstable to transport. So there are challenges, no doubt, on both the sending and receiving end and deciding if a patient is able to be transported. And there have been plenty of examples in the past several days where we're working with a sending hospital to manage acceptance of a patient here who just is too sick at the moment to travel. So they may be sicker. I don't know that they're sicker because they're being flown or because there's a delay in transport, but more just that there are a larger number of patients needing critical care than we normally see at this point in time.
Thanks.
Any other reporter questions?
I've got one. It's from NPR, and it dovetails on the AP question. the reporter's wanting to know if you have updated numbers on the number of rural transfers and those being rejected and the ratio perhaps to other. So I know you're not prepared,
Yeah.
but at last check, or what's in your...
So we do look regularly at the number of COVID-19 patients in a time period that are, or the percentage, I should say, that are in our hospital that come from the metropolitan area, so counties in the metropolitan statistical area, or and then the percentage that come from other counties outside of the metro area. That has remained relatively stable now for a couple of months at about 70%, 67 to 70% being from the metro, and the remainder being transports in. Those transports in are coming from a larger geographical area, and of course that percentage is of a higher number of COVID patients. So in general, raw numbers, I think it is probably safe to say there are more transfers in, both for COVID and probably for other things than we would have on a normal day or week or month. But I also know that we normally get between 800 and 1,000 transfer calls in any given month, and we are normally able to accept because it's appropriate to do so, and we can offer the service somewhere between 550, maybe 525 and 600 of those per month. And we're pretty much on spot for the same number of acceptances over the last 2 weeks, but I do think it's probably true that the total number of calls and total number of denials, because it's unsafe or because of capacity, has increased.
Cake TV, Chris Hunter wants to know, in Sedgwick County, he said we saw a sharp decline from 450 cases per day to under 200. And he's wondering if what might have accounted for that, and if doctors have a concern that this is a false sense of security. What would cause that big of a drop?
So I'll start, and Dana, you may have something to add.
Yeah.
We know, well, first, I'm assuming that this drop that you're describing is from the 27th of November on, because the peak in the state, and I would assume in Sedgwick County, of number of new cases per day happened around the 26th of November. We know that in that same time frame, we ran significantly less tests. There were less specimens, so we would expect less positives. Whether or not it's a false sense of security, I don't know, but I think it is directly related to decreased testing over the holiday, a smaller number of people being tested, and therefore a smaller number of new positives. Dana?
Yeah, I would totally agree. I think we need to be cognizant of that fact, actually, and kind of see what this next week brings us. But also, I don't think we are out of the woods as far as total hospitalizations. I don't think we will know that really until, say 20 days from now, because we still, in general, around the state, there was such a high or a steep curve of the increase in cases before we saw that kind of peak that we're talking about. So we know that the hospitalizations lag behind that by about 10 days, 12 days. So I think from that standpoint, from hospitalization standpoint, even if that proves to be true as far as number of cases, from number of hospitalizations, I think we still have a lot of stuff in front of us that we have to be prepared to deal with, and a lot of patients that could potentially be coming to the hospital.
I would agree. The transfer calls yesterday are not down at all.
Yeah.
So
That concludes my reporter questions, so we can welcome Dr. Harris.
great. Well, good morning, Heather. Let's start with you.
Good morning.
Hi there. We know that HaysMed lately has been running at a higher volume of COVID-19 patients than earlier in the pandemic. I think mid-30s in the hospital most days, which is, I think, around a third or so of your total beds. How is that impacting healthcare services and your team there in Hays?
Yeah, so our hospital's been full, and I say full for staffed beds. I think we need to always make sure we're defining, that we have the staff to take care of patients. So, yes, our average census for probably almost the last month, if just for COVID patients alone, has been in the mid-30s, which is about almost half of our staff beds, just short of that. We're caring for up to 40 counties in Kansas, so we have a huge referral area. The average age is around 76, so they're getting a little younger. Actually, in the last month, we've seen that number go down a whole year in average age of people being hospitalized. Since April, we've had over 300 patients hospitalized for COVID, obviously the majority of those being in the last few months. I think the most impactful thing for us is that we have had to be closed to transfers more than we've ever had in the last almost 14 years, just meaning, that the patients are sick. They're here for a long time. Average length of stay is 10 days for these COVID patients, sometimes longer, which, as you know, in the hospital world, that's a long time anymore. And so it's just for the month of November, we've unfortunately had to deny 103 transfers from other hospitals, which is why you guys are seeing those transfers from even further. So it's taking a long time for those critical access hospitals to get patients moved if they're too sick. And I have a stat today that we had only had to do that 2 times in the last 14 years. So it's definitely, an intense situation for the hospital and the nurses and the physicians working there. So, I think that some of the rural areas felt like maybe they were protected due to their geography from the virus, and clearly that's not the case. We've got a couple of counties that still don't have a mask mandate, and those 3 or 4 counties alone have been almost 30 of our inpatients. So, I think that the rural folks need to really be cautious as well and, wear masks and try to, social distance and don't gather in big groups and try to protect yourself so you don't get sick.
You made so many great points there. Before we jump too much into them, you described 2 scenarios that are really challenging for healthcare workers. One, being full for a long time, right? Taking care of a lot of sick patients. But 2, having to say no, having to decline transfers. I think we all want to provide care to everyone that we can. How are your teams holding up given those factors?
Yeah, you can see the strain for several reasons. One, the providers and the physicians, not being able to accept those patients from these local or other local areas is very stressful for them. That's not why we go into medicine, is to not be able to care for people. So you can feel the strain on that. And I think the other thing is, people are dying from this illness. And I see that being a strain for both the nursing staff and the providers. When you care for people for 10 plus days and, the patients can't have family in the hospital, you become connected to those folks. And we're in the, business of healing people and making people well again. And so I think that's a huge strain for people too. So people are getting weary. People are strained and stressed and sad.
How are things in the ambulatory environment? Are you seeing more COVID positive patients in your clinics as well?
Yeah, I think the whole month of November, well, I can tell you November the 9th, 9 days from Halloween conveniently, which we kind of knew that was going to be the next rush, has just been constant. We're running an average of about 27-ish, 30% positive-ish up and down through the month of November. So it's just been really steady. Our testing, we're testing almost somewhere between 60 to 100 people every day, for which out here is a lot of people, for our system to manage and to be testing, because our team didn't grow much, but we're creating lots more work, as you guys can, embrace as well. So, it's just been a steady since November. I think that the numbers decreased, like you said earlier, I think everyone hopefully thinks, we made it through Thanksgiving because the numbers on Monday were better. Well, that's because nobody tested. So, I think today and probably Friday will be some increased numbers again, is my guess, and definitely in the next week.
I would just like to say, we had talked about that, and the other reason I think is because maybe people, I know I got texted, Wednesday evening, Thursday, Friday. I think people had symptoms then, and then by Sunday or Monday, their symptoms got better. So I think, echoing on your point, I think that's one of the other reasons maybe even those people that were ill maybe didn't go get tested because they couldn't get tested, say, Thursday or Friday. That could be another reason why.
Yeah.
Sure.
Yeah, no, I just think it was a lot bigger challenge to get tested, and they were already home out of work anyway, so they weren't missing much anyway. So just stay home and get better, which is important to do. So
you have a sense.
But I think Monday Go on.
Sorry, I was just going to ask if you have a sense of how many of the patients really know their point of transmission. Do they know the contact that was positive, or is it really hard to tell?
I think both. Definitely I got together with family or friends. I went to a wedding. I went to a funeral. You still hear some of that in about maybe half of it. Maybe a coworker, things like that obviously they're not wearing PPE in those break rooms and so forth. So you're still seeing some of that. And then a lot of it, probably over half, really, I don't think people know where they've gotten it. I asked a question, have you been around someone? But I don't know that the question is all that important anymore at this point, because lots of people are just shocked, because they didn't know that they were around anyone that had been sick. So, I think you have to be careful in all settings now. And I think the other thing, what other thing that people forget is obviously we don't want, people get sick with this. They're in the hospital a long time. And then I think, a good majority of the folks that do get hospitalized, they have a lot of morbidity when they go home. They go home with oxygen, they're weak. I think it's going to take several months for some of those people to get, well again. So the illness certainly has some long-standing complications for sure.
Sure. And what about the impact on the healthcare workers there in Hays? Are you seeing healthcare workers test positive, or do you have a number of employees that are out because they're positive?
Yeah, last week for sure we had over 20, I believe, which really impacts us because we don't have a lot of extra folks anyway. This week it's a little better. There's still some positive employees out, but that number has decreased some. So, we're really, encouraging staff to also make good choices socially the best that they can, and really limiting break room use and things like that as a group so that we can keep our staff intact, because that's very important. Because if we have staff, that is not available to work because they're sick, then that also impacts our ability to care for more patients.
Sure. I want to get to Kevin and a couple of questions from your perspective, but first I think there might be a question from a local reporter for you, Heather.
Okay.
Dr. Harris, this is Christina Gianni from the Hays Post and Eagle Radio. Has the ability to care for patients who are non-COVID, such as heart attack or stroke, has that been affected by the number of COVID patients you're caring for?
Right. So when we closed for transfers from those other critical access hospitals, those 103 patients for the month of November included, an appendix and some other, an AFib and some other non-COVID related patients. We're always open to STEMIs, which is an acute ST elevation heart attack, and I believe acute strokes. But yes, we've had to, unfortunately, when we're closed to all patients from outside Ellis County when we can't take those transfers. So absolutely, that's impacted that care as well.
Christina, I would maybe add a little. It's not local to Hays, but I think it's a pattern that is playing out in a number of hospitals probably most hospitals across the country right now. Yesterday, we had 59 patients in ICU beds in our hospital, either acute for acute COVID disease or recovering, but still in the ICU. 59. That's 59 patients that would not have been here before, right, if we didn't have COVID. And there is no doubt that means that people with other healthcare conditions, other diseases, some of them chronic, but many of them acute needs, are having to either travel farther for care or wait longer for care. So there's no doubt that there is an impact on patients across the community with diseases other than COVID.
Right. So you can imagine our hospital of about 85 to 90 staff beds, when a third or almost a half of those are COVID. And then we today have 7 intubated ICU patients here in Hays. So, and that's just COVID patients unrelated to heart attacks or heart surgery, and et cetera. So absolutely, it's impacting those other illnesses as well.
Thanks. So Kevin, it's good to see you. How are you and your staff holding up?
Good morning. Doing well. I mean, it's all about resilience at this point. We have staff holding up well, but it's definitely a lot of fatigue, tired, and just everybody's the comment you kind of hear, like everybody says, is, when is this going to be over? Or for me, it's over. And it's just hard because you want to let it go. You're tired of, at some days, fighting the battle. We're all humans, right? We have moments of it's just hard to get up in the morning because we're going to just kind of do Groundhog Day again. But the care and the resilience of, I know I'm important, I know I need to be there, is definitely a forefront in the staff. And you can really see that starting to unfold for many. We all know how important it is, how real it is. And it's, for us as leaders, we're really trying to do everything we can to support our frontline staff, and everywhere from the physicians and providers also to all the ancillary staff, because it's important to remember everybody at the hospital setting, at the end of the day, everything they do is touching that patient on some level. So it's important that we're trying to remove barriers, help our staff, keep encouragement, keep smiles on faces, make things happy at work, to do our best during this time. So it's definitely been different ways of challenging ourselves to attack this differently with our staff because of the things that COVID brings with it.
Yeah, no doubt. I think those things you describe, right, making sure that everyone has something to smile about still, and the impact of that both on our staff but on our patients is very real. I remember, it's been several weeks now, but I remember when I was last in Hays, I was very proud to see everyone greet me with a smile and say, we've got this, even though they were working hard. So congratulations and thank you to you and your team for helping keep that spirit and attitude. It's so important, alive out there with your teams. We also hear sometimes anecdotally and sometimes directly from patients that they're really surprised that they got COVID-19 or are really surprised that they are so sick. Are you finding that to be true in your patients?
Oh, absolutely. You hear all kinds of stories, and like Heather said, it's you even have to ask anymore where people got it, but it's always comes up in conversation. It's always good to kind of understand with contact tracing and to help things as the big picture. But we still see a lot of patients, I can't believe I have this. So for me, when I interview them, I think a lot of it's just kind of that denial. I've made it this long with fighting it off and avoiding it, and I've been trying to do the right thing. Then I finally got it. So sometimes the first reaction is, I have no idea where I got this. Maybe usually when you probe and dig a little deeper, you can find strands of maybe where some connections happen, see if it's important or not. But yeah, people, there's still that pocket of people that just believe it's not happening, or we don't want to believe it is, or just want to say it's not real. And then when it finally kind of hits the home front, they have a lot of questions, and that's why it's important for us to be there. I take phone calls probably daily on just what you would think would be almost common knowledge now or common sense, just because we've been living it for so long. And it's like starting over on day one with certain people, which is totally fine and totally appropriate. I'm glad I'm there to help them kind of get back up to speed, because they've just been suppressing it or denying it for so long. So our job too is just to continue to educate, continue to support, and remember that for when somebody gets it or somebody gets it first time in their family, we're getting used to it as healthcare professionals. We've been dealing in this with so many months, but when it hits a family for the first time, it's their first experience with it, and we have to remember that and be there to support them and help them through it.
Sure. As an infection preventionist, you hit on a number of things that are important to be able to educate community, our staff. I'd pivot just a second to talk about the impact of PPE. We know how important PPE is in protecting our patients and our healthcare workers. But we've also heard many stories from nurses and others who share how the PPE that they have to wear here makes it more difficult to have the human touch side of nursing or providing care with their patients, and also from patients who feel that impact. What's your experience been, and what advice would you have for our staff who are weary even from that PPE piece that's so important?
It is, and people are trying to get creative, and I get quite a few questions on that from staff on PPE. I want them to see my face. I want them to see me smile. It's important that you're able to read my lips. It's important to see my facial expressions, which is another proud thing. Like, you want to hear that staff are really know how important it is to make that connection with patients and families. And how do we do that with PPE and the limitations we have that? and it's getting creative. People are asking me about the different types of masks and clear and face shields, and can I do this, or in this moment, can we make an exception? So it's looking at these things, kind of critically think what the situation is, where we're at, with every case is almost a case-by-case experience. What can we do to make it safe and bring in that kind of human need or human experience and human touch that our staff want to bring to really bring in that empathy and be supportive to families and patients, and without what's the word I'm going to break the safety of exposing ourselves or making it worse on somebody else. So we continue to look for options, and we continue to help, is it stay 6 feet apart, drop your mask for a few moments, or put the face shield on, anything to make the experience better while still staying safe. So we'll continue to work through those kind of things daily.
And with the current rate of disease in our communities and transmission, what worries you most about the next few weeks?
I think what worries me the most, I guess, is it's the continued, I think the spike's going to continue, as you guys were mentioning earlier. These could be false numbers. Everybody sees the kind of long journey ahead that's there, and then mixing it in with the flu, other viruses that happen through the winter that are common. And what does that mean? There's starting to be, we all can see a struggle with that. I'm concerned I have COVID and it ends up being the flu, or ends up being strep or something else, or it's just a 24-hour bug that just went away and not COVID, but there was testing involved, there was quarantine at the time, there was a lot of stress. And that's what seems to be getting harder to make me let myself sleep at night, that kind of work that's coming up for everybody in the future.
Yeah, makes sense. Jill, why don't we move on to some community questions?
I'm going to start with Cindy's question. She comes from a small community, and she wants to know from Dr. Harris and Kevin. She said in smaller communities, you tend to know everyone. And she wants to know, have you ever walked into a room to see a neighbor or a church member, and how has that made you feel? Kevin?
Yes, I'll start with that. For how it makes me feel, and it happens a lot. It's amazing when you come from a small area and how many people you run into. I mean, that's why a lot of us are here, is because we're trying to help our families and our loved ones and our friends and our friends' friends type of thing. But this, I don't know if it's the word satisfaction, but it's a kind of a privilege feeling to go, I can be here for you, and I know how much I can bring to you. How important it is to know somebody when you're in the hospital. There's a big difference when a nurse walks in, you meet her for the first time, or him, and discuss life a little bit and kind of make that connection. But when you already know somebody, the confidence that brings to a patient makes me feel so much better, makes the patient feel much better. Even if it's a long-term connection, it could be somebody I haven't seen for 10 years, but as soon as that patient knows somebody in the hospital, they feel like they have an upper hand, they feel like they're truly getting a little extra care. And it's so important, and it brings a kind of an uplift, I guess would be the word for me. It's an uplift where I'm really here for you, and I can't wait to help you and be that support. And I'm glad you got a familiar face to help you through this. So it brings a lot of satisfaction for both parties.
Yeah, thanks. Heather, your perspective?
No, I mean, I just echo what Kevin said. I mean, I think that's why providers work in community hospitals, is because we get to care every day for our family and friends. There's rarely a stranger anymore when you're here, as long as I've been here. And so that I hopefully supplies some comfort for the patients. And certainly, we have another layer of empathy for our patients. And obviously, if people get sicker, it creates obviously some more, another layer of sadness for us. But no, I mean, that's why that's just the benefits of taking care of folks in a community setting like we are, is that, I think it allows us to care even more.
All right. We have a couple of questions here, too, that are related to the vaccine. One of them is, Nicole wants to know, she said, I have a 74-year-old COPD patient who's been living at home since March in isolation. And she wants to know, would she be a candidate for the vaccine, and is it safe for her?
Dana?
Well, it will be safe. I mean, I think if we're talking about the Pfizer and Moderna, again, we don't know all of the safety data from these vaccines, whether it's Pfizer, Moderna, AstraZeneca. So far, what we've been told and what we've seen is that the safety profile is very good. So I'm going to say based on that, and based on the, the CDC moving forward and the vaccine group moving forward saying yes to give these and who to give them to, I'm going to say it's safe based on that. Would the patient be a candidate? Would that person be a candidate? Absolutely. I don't know all the full details. We know that healthcare workers are first, along with the nursing home facility patients. But I would think that patient is very high risk, and so there has to be some means in there to get those high risk patients vaccinated as well. But absolutely, I would say so far, based on what we're seeing, it's safe. And when it's available, I would certainly recommend getting one of the vaccines that are available and will be under the emergency use authorization or approved when that happens, when and if that happens.
People want to know if Hays is going to be a hub out in western Kansas for vaccine. Do we know? Distribution?
We're going to have the vaccine, but we're not going to be I don't think we're a hub storage. I think Wichita is the closest for the Pfizer, just due to the storage, is my understanding. Do you gentlemen have any other input on that?
Yeah, there has been, it's been pretty quiet just because they want some level of security and protection. So we don't know all the details about who will be a storage and distribution hub, either coming from the state or from the CDC. Again, mostly for security reasons. So they have been pretty hush-hush about that. But I imagine that will start to unfold, and we will know more in the coming 10 days, 2 weeks, 20 days.
Don't know if you know the answer to this either, because we're going to talk in depth about vaccines next week. But Amy wants to know, will frontline hospital employees who are pregnant get the vaccine? Any word on that?
I don't know that we know about the pregnancy information. I don't know how much it was tested in pregnant women. So I think, certainly the nanoparticle one should be safe, the Moderna Pfizer one. Again, this is just speculation. I'm not really sure about the AstraZeneca being with that adenovirus vector, but I don't think that there's been a lot of studies in that pregnant population.
Nancy says, I've been walking outside. With the colder weather coming, I usually go into the mall. A, do you think that's safe? B, what do I wear?
Well, I mean, I think it's probably still going to be safe. I think you can understand what times you're going. Will the mall be more busy or less busy? Is it a weekend or a weekday? Definitely try to go when it's less busy. If you have your mask on and you are moving around people and not meeting in groups and walking in groups and with other people who are not in your household, I think it can be safe. Certainly try to walk outside if you can, but obviously you're going to want to be wearing that mask.
Multiple people are asking if a shortened quarantine period will keep the virus from spreading.
It's a great question.
Yeah.
We're sort of looking at each other and laughing because there's a long text string among a group of us that wonders many of these same things.
Yeah.
I think the answer has to be the same right now. We fully believe that a recommendation from the CDC to change quarantine guidelines would be based on evidence that shows that it's safe, or that the risk-benefit of making a change is safe for the community. So I'm confident in that general response, but we'll see.
Yeah.
I think the quarantine period, without a doubt, is aimed at preventing transmission, reducing transmission in our community. And so I think in general, that's the goal. We wouldn't do anything from a public health perspective to change that.
Yeah, I totally agree. That is a great question. That's unanswerable right now. But we know if you're doing those other mitigation strategies with the masking, with the distancing, based on some of those smaller studies, the studies that showed that the hairstylists who used masks and their clients used masks, none of the clients that they were able to interview came down with the disease. There's a recent publication as well, a very small study looking at 3 different dental offices in the New York City area where all of those mitigation strategies were done and there was no spread from the healthcare workers to the patients during that time. Again, it was a small sample, but if you're doing the masking, the distancing, and not meeting in other large groups, hopefully that will also help to decrease the spread, even if there is that shorter quarantine period.
Great.
A comment and 2 more questions. Gretchen, she wanted Kevin to know, hey, I've seen some people take faces of themselves smiling and put it on their PPE. She says it makes a difference.
A great idea. Yeah, that's another creative idea.
We'll send more along as the community weighs in. They're a good bunch that are listening. Nancy Kim says, if everyone in the family has COVID, does it add to anyone's virus load if they isolate together?
Dana?
Isolate together in the same household. You know, I don't believe that it does. I believe that the amount of virus you're expressing is probably going to be much smaller than the amount of virus you're actually replicating in your upper respiratory tract or down in your lungs if you do have COVID-19 pneumonia specifically. So I don't think there's a lot of risk there. This is a question that we've dealt with when we've talked about should we, if we do run into bed and room capacity space, do we need to put COVID patients together? Or if there's members of the same household who come into the hospital together, are we able to put them together? Again, the beds are still separated. If you can still maintain some separation in that household, that's okay. But I don't believe that there is a large amount of virus that is going to contribute more to your illness, more than what your body's actually replicating during the actual viral period or viral phase of this disease. But again, certainly wearing masks in the household has shown to be effective and help as well. So if you all have it, I think you have to really consider continuing to distance and wear masks in the household for that 10 or 14-day period, as long as you're isolating together.
Last question is going to go to Mike. He's a dad. His adult son did something that I'm not sure if the tone is an eye roll or an insert of a heavy sigh, but the question is,
Probably a teenager.
my adult son played racquetball with someone who was a recovered COVID-19 person. Is it safe for us to visit him outside with masks on Saturday?
Yeah, I mean, I think if your son was a, we'll say contact in this case, a contact of a COVID recovered patient, that patient should have done their 10 days of isolation from symptom onset, should be able to get back into society, and hence is playing racquetball. So there wouldn't be necessarily even your son being a contact or an exposure, because that person is considered cleared or out of isolation from the acute infection and in that recovery phase. Certainly, I think if you're meeting outside with masks on and a distancing 6 or 8 or 10 feet, that should be reasonable to do, yes.
Great. Well, tomorrow we will take you inside our infusion clinic, where the first doses of the monoclonal antibody bamlanivimab is being given to patients. Shannon Schroeder is our infusion therapy clinic manager, and she also gives these infusions to patients. So look forward to that. Dana, final thoughts this morning?
You know, I think we had some good thoughts from Kevin and Harris, and I would kind of want to echo on some of their thoughts. You know, it is tough to find joy. They were talking about how do you get up and how are you resilient every day. It takes just finding that little bit of joy every day, whatever that might be. You know, hugging a loved one, whether it's walking outside or walking in the mall, seeing a sunrise or sunset. Try to find that little bit of joy every day, whether it's saying prayers or going to service or anything like that, because that is important. Because, you know, although we're not rounding the curve yet, I think we are leading up to the straightaway to round that curve. And we have to see really what happens with the vaccines. But I think there is a light at the end of the tunnel. Let's get through these next 4 or 6 weeks, see how things go, see the ultimate supply of the vaccines, and really how safe and efficacious they are when they present that data, and if they are EUA or if they are approved. But I think there is some sort of light at the end of the tunnel. We just have to continue to be resilient and find that little bit of joy every day in life.
Kevin, any final thoughts?
No, I think that was perfectly said. I was really enjoyed what you just said there, so I agree, echo that. I find that joy, and we can move forward, no problem.
Thanks. Heather?
Yeah, I just want people to keep really for this, where I feel like we're getting closer to a finish line, not the finish line, but a finish line. And if we can just, keep lowering the curve for people to not get critically ill, particularly in those high-risk groups, I keep telling everyone you've gone this far to stay healthy. Just give everybody a few more months, and I think the spring will look better, and we can all have a late Thanksgiving.
Great, thanks. I think it's easy to feel like we don't have control or we're out of control in the current situation. And all of these acts of gratitude, finding joy in your life, all of the things that we've described are important. But I think it's also important to remember that you have a lot of power. Each of us individually have a lot of power in what the next weeks and days look like. And so I will echo the urge and the ask to stay resilient, to remember that the pillars of infection prevention and control that we have been sharing daily now for so many months remain a great tool, a great amount of power that you have in your community, in your daily life. So as we say goodbye today, we hear from Lynn Flora. She's one of our nurses who works in our endoscopy area. She spent 60 days in our ICU on a ventilator because of COVID-19. Her message is simple. Everyone, please wear a mask around anyone who's not in your bubble, including your extended family. It's much easier than trying to survive COVID.
I think the thing that broke my heart the most was my daughter has 2 small children, and she had to have the talk with them about Grammy's probably not going to come home.
Lynn Flora's daughter, Ashton, although had hoped for the best, had to prepare her kids for the worst.
My breathing had deteriorated to the point that I knew I needed to get somewhere. I never in a million years thought I would ever contract COVID.
But she did, and spent 60 days in the ICU on a ventilator.
They had called the family in and said that I had maybe 2 weeks to live.
Lynn, who's a nurse, knew right away it was COVID-19.
But I had severe muscle cramps, shortness of breath.
Her condition rapidly declined.
They intubated me on my birthday, August the 7th, and began to wake me up early to mid-September.
Something her daughter prayed daily would happen.
I text my daughter every morning and say, did you make it to work? And the first time that I was able to text, she literally broke down. She said, I have waited so long to get this text from you, Mom.
After 2 weeks of rehab, working to regain muscle strength, Lynn feels better, but doctors still aren't sure of the long-term side effects of COVID-19 and weeks spent intubated.
You see this COVID-19 and you see other people going through it, but I don't think it really grasps you until it's somebody very close to you that's going through it.
Lynn has this message for others.
Continue to be vigilant about wearing your masks, washing your hands, where you go, who you're around. And if you do contract this and feel like you're deteriorating, don't wait. It makes you look at life a little differently. Life is fragile. Life is all about living like this is your last day.